today. I'm going to spend the first half of my talk talking about primary headache disorders and then get into secondary headache disorders. So I want you to put yourselves in the seat of a physician. And you have this lovely woman named Barbara, and she is an artist and has given permission to use a picture of herself when she has a headache. And for those of you who have ever had a migraine, they know exactly what she's talking about. This is a 32-year-old woman. She's had a headache since age 12. They're extremely severe. They're stabbing, they're throbbing, they're jabbing, and she feels like there's a knife through her left eye. She has nausea and vomiting, and she has these very interesting symptoms. It's as if your sensory gain has increased when you have the headache. Her scalp hurts. She can't wear earrings. She can't wear anything around her neck. She feels bruised. Light hurts, just normal light. Sound sounds very louder than it is. And she has to stay in bed. This disables her for 1 to 1.5 days, and she misses work. So with that, I want you to keep this case in mind, and let's talk about the difference between primary and secondary headaches. Primary headaches and secondary headaches were divided into two general classifications really in the late 80s. So before that, we really did not have good definitions of headache. It was different to do clinical trials, to do any evidence-based medicine, because headache is a very different term for different people when you use it. So the International Classification of Headache Disorders Committee, one evening, probably with a lot of very good Italian wine, sat down and decided what they were going to call a migraine, what they were going to call a tension-type headache, or a cluster, or a group of headache called trigeminal autonomic cephalalgias, and other primary headache disorders. Now, some of these primary headache disorders are important in that there's no underlying pathologic reason. For example, cough headache that I'm going to talk about later, sex headache that takes people to the doctor really fast when you have a headache that hits you like a baseball bat in the back of your head at orgasm. And some of these can be symptoms of secondary headaches which have underlying pathologic issues going on. For example, post-traumatic headaches, headaches associated with subarachnoid hemorrhages, etc. So what would be a red flag? What would be something that would make you, as a physician, very, very nervous about seeing someone with a new headache disorder? If it's the worst headache of somebody's life, if it's the first headache, and even if you saw that woman, but she's been telling you since she's had headaches since age 12, so it makes you feel a little more comfortable that this isn't something that's going to be very severe or serious. If it's a new headache pattern, you always get worried. So I might see someone with a migraine, and she says, oh, by the way, for the last 6 months, I've been waking up with a little bit of headache. It's a little different, but it goes away in 2 to 3 hours. And now it's going away in 4 to 5 hours. And so you can have two things occurring at the same time. She had migraine, but she also had a large epidermoid tumor that was successfully resected, and she went back happily to having her migraine. Change in headache pattern you always have to look at. Progressive headache syndromes, where people get worse and worse and worse. They have more headaches, they have more frequent headaches. Onset with Valsalva or intercourse. Again, we're hearing Dr. Watson talked a little bit about Valsalva. I'm going to talk a lot more about that. Abnormal neurologic examination or swelling when you're looking in someone's eye. New headache over the age of 50. That hurts me a great deal. But, or if you have a history of cancer or HIV, cancers that metastasize to the brain. HIV, which as we know is associated a lot with things like toxoplasmosis or primary CNS lymphoma and some other things. So what are we talking about in terms of people with headache? We're talking about practically everyone. And if If there's someone in this room that has never had a headache in their life, I'm really jealous. But if we're talking about tension type headache, about 50% of the population has headaches. And I'm talking about now here more than 2 per month. I think if you're talking about lifetime prevalence, we're talking maybe 90–95% of people in the world have had a tension type headache. If we talk about migraine, a moderate to severe headache, and really the type of patients that physicians will see, because this group is going to go to Costco or Bartell's and buy their ibuprofens and 250 and their Excedrin migraine. But we're talking about less of the population, but still significant. Chronic daily headaches, people that have headaches more than 50% of the month, about, again, 4 to 5% of the population. So migraine is very common. This is an age and gender prevalence curve, and you can see that women will get migraine 3 times as often as men, as they do in a lot of other things. We heard a little bit about fibromyalgia. We heard in multiple sclerosis it's that way, in many of the autoimmune diseases. We think, however, looking at this prevalence curve that really has a high incidence, and the highest incidence is about the time of the onset of someone's menstrual period, that this is very associated with hormones, because you get this big drop in prevalence somewhere between about 45 and 55, about the time of menopause. You still have a little bit of a drop in men, not exactly sure why, but it's thought that perhaps it has something to do with serotonin receptor density or sensitivity. But these are really peak work years for people. So again, this can be very disabling. What causes headaches? If it's a primary headache disorder, you're going to be born with it because you didn't choose mom and dad well. A headache brain is inherited. It's hypersensitive and hyperexcitable. If one parent has migraine, there's a 50% chance that a child is going to have migraine as well. If both parents have it, there's a 75% chance. And there are certain triggers that can make these headaches happen. For example, in women, 60% of women who have migraine will have their onset of a headache predictably 1 to 2 days before their period to 2 to 3 days afterwards. And there's nothing you can do about it except wait. So how do we differentiate between migraine and tension type headaches? Well, in a nutshell, if people have migraine, it's always going to be a moderate to severe headache. You're not going to go to a doctor for a low impact, mild headache. You just don't bring that up to the physician. It usually will last 4 hours to 3 days. It's often one-sided, but that's only 60%. And it can be exacerbated by routine physical activity, bending over, tying your shoes, running up the stairs. No one wants to do Zumba with a migraine. And there will either be nausea and or vomiting or light and sound sensitivity. So that's the definition that was put together by the International Classification of Headache Disorders. This is a very mild type headache. Physicians primarily see migraine. For those of you that have not had the pleasure of experiencing a migraine, 50% of people know when a headache's coming. And it can be, it's very interesting. They can have food cravings. We think chocolate causes migraine, but it's probably craving carbs. Your sleep may be poor a few days before. You may have more yawning. 20% of people have aura, twinkly lights that could happen before the headache happens, sometimes numbness. And then you have this relatively different speed of a peak of pain that again may last 4 hours to 3 days, and a drop that feels a lot like a hangover to some people. Why do we feel pain where we do? And again, just like in real estate, location, 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 many people will come to me and say, I have a sinus problem because my headache is right here over my forehead. And so that gets us into this headache as being a referred pain syndrome. Just like in a heart attack, it's really your heart that's the problem, but you might feel the pain in your arm. So without having a lot of time to talk about this, Dr. Wolf, many, many years ago, did experiments on awake patients where he would touch or tug at different parts of the dura, the lining around the brain, because there are certain pain-sensitive structures. And depending on where he did, you could reproduce pain in a certain portion of the patient's anatomy. Primarily, people experience their headaches in a quadrant over the temples, but it can be holocephalic. It can be the whole head. So location doesn't necessarily mean there's an underlying etiology to that. There's been a lot of patients. My record is someone who's had 13 sinus surgeries for migraine. And it certainly didn't help her headaches. So the referred pain can be anywhere in the trigeminovascular area. Most people, again, V1, some people V2, and they really think they have sinus problems. Some people will even get a migraine in their teeth, and that their dentist's having root canals. But there's also input into the trigeminal nucleus caudalis, which we think is the mom of where headache is generated, from the back of the head and the upper part of the neck, and what I like to call the Arnold Schwarzenegger muscle, the traps, the anterior traps. He'll be back. So people can experience primary headache disorders in the back of their head and their neck as well. We think that the migraine starts in a group of cells in the brainstem. So whether it's a generator or a modulator, it's close to the back, called the raphe nucleus, really close to the locus ceruleus, and the periaqueductal gray, which is very important in terms of pain pathways. The brain itself, remember, is insensate, and so the experience is going to be experienced somewhere in the anterior cingulate cortex. How do we know this? This was done in 1995 in a German group, Hans Diener's group, where you took 15 patients with right-sided migraine, put them in a PET scanner, and found that they had increased regional cerebral blood flow here in this portion of the brain, close to the raphe nucleus. They also had it in the anterior cingulate, and you can't see it on this picture, but in auditory and visual association cortex, probably corresponding to light and sound sensitivity. Then you pull these people out of the scanner and you give them 6 milligrams of Imitrex, which, as many of you know, is a specific drug that treats migraine. Waited till the headache resolved, put them back in the PET scanner, and found that all these increased areas of blood flow resolved except for this one. So if you brought them in then 3 days later, that was normal too. So people inherit how this generator turns on. You know, maybe it's 1 day, maybe it's 2 days, sometimes it's 3 days. Migraine's a transmission problem. I don't have time to talk about the genetics, but it's interesting that now we've looked at three different chromosomes which reflect exactly the same symptomatic headache. Triggers can be diet, sleep deprivation, sometimes too much sleep, sleeping in a hot room, hormonal changes that I briefly mentioned, even exertion and exercise can trigger a primary headache disorder. Stress, anxiety, head trauma, or whiplash. So if you've diagnosed a primary headache disorder, as you saw in the woman that we started with, then you try to figure out if there are any triggers that you can help people with. You can lead a horse to water, you can't make them drink, but if someone's sleeping 5 hours and they're drinking a lot of red wine and 6 cups of Starbucks coffee every morning, there may be some modifiers there that they will be willing to do. Acute treatment, we have wonderful migraine-specific therapies now, the triptans, dihydroergotamine, and some people who have many, many headaches a month need preventative treatment. These are drugs that you take every day to try and decrease frequency and intensity of your headaches. Drugs like the epilepsy drugs or beta blockers or calcium channel blockers. What they have in what they have in common is that they decrease the hyperexcitability of these pain-sensitive pathways in migraine. So I'm going to switch now and talk about secondary headaches, and there are so many that I really want to focus in on basically headaches that can be associated with Chiari malformations. So here's another patient, and maybe this person is going to walk into your office. He's 37 years old. He has a long history of headaches that sound like migraine, but he's really never gotten the diagnosis. And over the past 3 months, his headache frequency increased. He had a normal exam, but because he was older, he had an MRI that showed a Chiari malformation type 1 that we've heard about earlier. And he was referred by his doctor to a neurosurgeon to see if he should have surgery. So his only symptom is headache, but as we've just heard, headache occurs in 28 million people in the United States. So is this something that is reflecting of a symptomatic Chiari malformation or not? So we really have to use the history to help us. Localization of headache in Chiari is often occipital or nuchal in the neck, but it can be generalized. So again, location, location, location helps, but it's not 100% deal breaker. 30 to 40% of patients with Chiari report headache precipitated by Valsalva. So you sneeze, you laugh, you strain on the toilet, you lift something heavy, you bend over. But again, some of the primary disorders do that as well. But that's something to keep under your hat for a while. 20 to 30% of Chiari patients report cough headache. Sudden onset, short lasting, seconds to minutes, really, really severe stabbing pain usually of severe intensity. Goes away fast, comes on really fast. So this patient met the criteria for migraine, and he'd had migraine for many, many years. What the increase in frequency was about was something not having to do with a Chiari malformation, and he had no history of the type of headache that you would worry about with Chiari. In patients with a Chiari malformation, the prevalence of migraine and tension-type headache is similar to that of the general population. Because you have a Chiari malformation doesn't mean that your chances of getting migraine or tension are greater. Yes, you can get headache as a symptom, but you have to differentiate it from the primary headache disorders. He was asymptomatic otherwise, and it was recommended that he not get surgery. Here's a 48-year-old man. He has a 2-week history that headache that developed after he had a very bad cold and bronchitis. If he coughs or sneezes, he has a sudden onset, really sharp, severe, brings him to his knees type headache at the top of his head and the back of his head, and it lasts 20 seconds to 2 minutes. Sometimes he'll have a dull headache that lingers for a few hours. And in fact, this is really similar to coital headaches, a secondary headache, or sex headaches, as people like to say, that at orgasm, it's, again, like you're being hit at the back of your head with a baseball bat, really, really severe for a few seconds. People usually stop what they're doing, and then you get this dull headache that can linger on for a few hours. That always brings people to the physician because there's a very small chance that this could be a sentinel bleed from an prior undiagnosed aneurysm. And so everyone with a sex headache gets an MRI, an MRA, and sometimes even an angiogram. His headaches could be triggered by lifting, but his neurologic exam was normal. So this can be a primary headache disorder. So it's a symptom of Chiari, but it also can be a primary headache disorder. And unfortunately, sometimes these are not very helpful. So he has a headache precipitated by coughing or straining, sudden onset lasting 1 second to 30 minutes, brought on by coughing in association maybe with straining and or Valsalva, and not precipitated by another disorder. So, you know, again, a primary cough headache is a diagnosis of exclusion. So the red flags in our patient are that he's older, middle-aged, hate that word, sudden onset, associated with increased intracranial pressure. He had to have an MRI because you really want to rule out anything in the back of the brain, posterior fossa, or any craniocervical lesions. Cough headache is symptomatic in up to 40% of cases, and most findings are going to be